Very good afternoon to all of you. Today I shall be discussing about the conventional corneal collagen cross-linking versus the accelerated corneal collagen cross-linking. It's a comparative study we have done. So as you all of know, the keratoconus is kerato means cornea and the conus means cones. It's a non-inflammatory bilateral disease which is characterized by the progressive thinning and apical protrusion of the cornea, which cause severe reduction in the vision. So there are several risk factors which also we found in our patients, so the genetic and the environmental risk factors. Apart from that, the first degree relatives and twins of the keratoconic patients. The other syndromes like say mentioned, the Leber's congenital amaurosis, the Down syndrome, the Ehlers-Danlos and the Marfan syndromes which can be associated with keratoconus, the eye rubbing and the allergic eye disease. Apart from this, the geographical areas with plenty of sunshine and hot climate patients are more vulnerable. And the ultraviolet light induced oxidative stress also has a role in the keratoconus. So the patients presented with the refractive abnormalities, the blurring of vision, the increased light sensitivity, the ghost images and diplopia. And on examination we can see like image A, the thinning of the apex of the cornea, followed by the image B which is showing the Munchausen signs. So it's a downward, on downward gaze we see the indentation of the lower eyelid. Apart from that, in the image C, you can see the parastromal scar, and in the image D, we can see there is a Fleischer ring, which is the deposition of the iron around the base of the cone. Image E depicting the Vox stria, which is the breaks in the Descemet's membrane, and image F denoting a acute case of corneal hydrops. So our study was a hospital-based randomized double-blind and a comparative study which was done over a period of 2 months, out of which the 18 months we collected the data and the period of data analysis was the 6 month. So our primary objective in the study was to study the effect of the CXL on corneal curvature and the corneal thickness in both the procedures and changes in the topometric indices and the endothelial cell density after the C3R procedure. Also, we studied in this study the effect of CXL on the best corrected visual acuity in the spherical and the astigmatic powers. So in our study, we have tried to assess the clinical outcome of novel minimally invasive procedure of CXL and AXL, and we have compared on the basis of the parameters like K1, K2, Kmax, the pentacam indices like IHT, ISB and IVA, the thinnest and the central corneal thickness, the endothelial cell density, and secondarily we also compared the best corrected visual acuity in both the cases and acceptance of the sphere and the cylinder on refraction pre and post CXL procedures. So here in our study we have taken patients aged between 14 to 32 years of age where the corneal pachymetry shown the thickness of the cornea was more than 400 micrometer, and the documented keratoconus progression was there. That is at least one of the following clinical signs in the last 1 year period. There is increase in at least 1 diopter of maximum keratometry findings, a 2% decrease in the central corneal thickness, and an increase in corneal cylinder of at least 1 diopter. We excluded the patient where we found corneal hydrops, so severe dry eye, or the patient refused to give consent, apical corneal scarring was there, or any active infection was present. So after initial evaluation of the visual acuity, slit lamp examination and detailed fundus examination, when you saw the findings in the slit lamp, and we proceeded with the investigations like pentacam, where both the Berlin Ambrosio enhanced ectasia and the 4-map display was shown. We followed in these patients doing after prepping the eye, we performed in 27 patients. We total took 54 patients, out of which in 27 patients we did conventional method and 27 patients we did accelerated method. So these patients were allotted in 2 groups, and the pre-CXL findings and the all the parameters findings at 1 month, 3 month and 6 month were taken into consideration, and the results are presented in terms of the pre-operative baseline, 1, 3 and 6 month post-operative period, and the changes were noted. Like these are the baseline pre-operative finding, all the indices, the BCVA, the accepted acceptance sphere and cylinder, K1, K2, Kmax, and all the pentacam indices. In the BCVA and the spherical and the cylindrical, we did not find any significant difference between the 2 groups. Although we found in both the methods there was a significant difference. There is significant improvement in the best corrected visual acuity in the spherical and the cylindrical power. In the thinnest and corneal thickness, central corneal thickness, and the intraocular pressure, we did not find any difference between the 2 procedures. But in the K1, K2, Kmax also we could not find any difference. But when we measured the topographic indices in the pentacam indices, in all IVA, ISB and IHD, we definitely found more improvement in cases of accelerated collagen cross-linking. So to conclude, these two treatments seem to be effective conservative management option in halting the disease. So both the procedure can significantly improve the morbidity and can be considered as effective and minimally invasive treatment. But definitely patient will be prefer more the accelerated C3R procedure because it takes less time and it's a better patient compliance and reduced exposure time, and there is also lower infection risk because of the reduced time of performing the surgeries. Thank you.
What is new in the study is, I think these studies, this type of studies I've done previously.
Pardon me, sir.
What is new in this study?
So this study we found definitely there is no significant difference in other indices, but in the pentacam indices we found it's better to perform the accelerated C3R because the difference in improvement of the pentacam indices like the index of the height decentration, the surface variance, it was better in the accelerated group.
So other references you have included?
Sorry, sir?
References?
Yes, sir. Yes,
this
sir.
type of studies?
Yeah, this type of studies has been done, sir, but they did not find any much difference. Other studies have found in the there is definitely improvement in the astigmatic acceptance of the astigmatic power, which is better in accelerated. But the pentacam indices, only the index of height decentration I have found in the studies, literature studies. ISB and IHT, we found that it is definitely better than the better in the accelerated group.
Have you compared your results with other studies?
Yes, ma'am. Okay, I have not mentioned here, yeah, but it's it has been compared with 10 literature studies, ma'am, and in 3 studies we have found there is definitely there is improvement in the accelerator, and it's better to perform the accelerator. Sir, 6-month follow-up period you have done, sir, after performing the surgery, which is definitely less. Yes, sir. Follow-up is short.
What was this a retrospective study?
No, ma'am, it was a prospective study. You
So
took
how did you calculate the sample size and whether it was randomized or it was based on the patient's, I mean, what were the confounding factors in this case?
It was a randomized one. It was a randomized studies, and as we wanted to compare these two procedures, so when the patients came, like we had already when we did not have the accelerated C3R machine, so when we had the conventional, the CXL machine, so we performed those patients in the CXL group, and in between after 10 procedures.
So that is not randomized, that's convenient sampling, it's called. Classically it's called convenient sampling. So
Ma'am, I was going to about that because we did not include, because total we had 74 patients, but as there was no machine, so we did not include those patients where there is only conventional was done because we did not have the facility. So after that we randomized.